Great. We good?
All right, I think we have Dr. Foley.
Sorry to
Should
be
be
late to the party, everybody.
No, you're good.
welcome. So I wanted to thank everyone for being here. We're going to get started because I want to make sure we're respectful of everyone's time. Dr. Powis will start the presentation and the introductions, and then we're gonna go on mute. If anyone has any questions, please raise your hands to ask questions, and Dr. Foley will call on you for that. Dr. Foley?
Me, you mean?
Take it away, Dick. I think he
Yeah,
means
sorry,
you.
go ahead. Yeah, go ahead.
Great. Welcome. Good morning, everyone. Good afternoon, Juma. Good afternoon, anyone else in West Africa who might be joining. Welcome to a conversation about sexual and reproductive health issues in Senegal. I'm very excited to moderate this conversation. It's just a conversation, so pretty laid back. We're going to do a little bit of, I'm going to introduce people. We're going to do some questions, and then we're going to turn it over to everyone else to ask questions in like the last 20 minutes. And if you do want to ask a question, please raise your hand and I'll try to catch that, or someone else might catch that. Yeah, just keep yourself on mute if you're not on the panel, and we'll go from there. The session is going to be recorded. There will be a link of the recording available on YouTube to watch later, study, share with students, whatever. Yeah, that's it for housekeeping. So, hello. My name is Dick Powis. I am an assistant professor of maternal and child health here in the College of Public Health at USF. And I'll take this opportunity to plug that I'll be teaching a global maternal child health course next semester at the graduate level, so you should all take it. Ms. Juma Nyang, Juma Khadi Nyang is based in Dakar, Senegal. She has a master's in project management from the Institut Supérieur de Management. She is proficient in French, English, Spanish, and native in Wolof. Juma currently serves as an associate in sexual and reproductive health at the Clinton Health Access Initiative, where she supports women's voice and local ownership initiative. Her prior roles include market analyst for CHI, the Clinton Health Access Initiative, assistant for UNFPA's SWED project, and project assistant for OCDEA. She has contributed to publications in healthcare access for disabled individuals and sexual and reproductive health rights in Senegal. Thank you for joining us. And Dr. Ellen Foley. Dr. Ellen Foley is a professor of sustainability and social justice at Clark University with a PhD in anthropology from Michigan State University. She has served as professor, associate director, and interim director in international development, community, and environment. Her research focuses on the intersections of health, gender, and policy in Africa. She has a phenomenal book which launched my career called Your Pocket is What Cures You, The Politics of Health in Senegal. She has been a pivotal figure in integrating health and social justice in academia, has numerous grants and publications that underscore that expertise in medical anthropology and global health. So very excited to have both of you here. Before we get going, I just want to give attendees sort of contextual, sort of some background about what we're going to be talking about. If you're not familiar with Senegal, if you don't know where Senegal is, I want to give this little lesson that I give all my students. So whenever we talk about Senegal, I like to bring up this map of Africa here on the left, the true size map. So for those that don't know, it is massive. It is huge. It's a lot bigger than people think it is. So when people say things like, how was your trip to Africa this summer? I think all of us sort of laugh a little bit, like, what do you mean? So there's more genetic, cultural, and linguistic diversity in Africa than there is between Africa and anywhere else in the world. It is massive. Senegal, there's a map in the upper right, is the westernmost country on the continent. So right about, if you're looking at the true size map, sort of where Northern California would be. It's about the same landmass as Kansas. It has a population of about 17.5 million people. Kansas has about 3 million people, just, for scale here. And then Dakar, we're talking about Senegal, but Dakar is the capital, and Dakar, which is in the lower right corner here, is the westernmost point of the country. It's a peninsula. It's a big multicultural cosmopolitan city. Official estimates put the population at about 4 million, and it's growing rapidly, although I think many people suspect it's much higher than that. The population density is actually a major demographic crisis. The population of the city is growing, and the city's on a peninsula. The peninsula is eroding because of climate change. It forces people to either build vertically or move further inland, and that's having a huge effect on land management, property development, real estate investment, housing security. And we all know, because we're all good at this, that those are all things that are very, very important to public health. So that's sort of the geographic and demographic context. Here's some really quick statistics. Thank you, Juma, for the last minute update to these, because I have not checked the most recent DHS. The official language of Senegal is French. About 37% of the population speaks French, and I think we can all agree that most of those people are in the major cities like Dakar, Saint Louis, Ziguinchor, and so on. National languages, though, there's a dozen, maybe. I'm not a lot of sources agree on that. But we definitely agree that Wolof, which is the most widely spoken language in the country, serves as the lingua franca. And what we mean by lingua franca is that it's the language that connects sort of everyone, whether you identify as Wolof or not, or whether your ethnicity is Wolof or not. Senegal is a largely Muslim country, about 96.8. That's the most specific number I've ever seen, Juma. Usually people say like 90 to 95. That's very precise. But to clarify, it might be a Muslim country, but it's not like an Islamic republic, right? So the government is secular. The GDP per capita is about $1,500 a year. I'm a little suspicious of that. Just for comparison, the US, I believe, is around 70,000 or 75,000. Literacy rate, we don't have good numbers on this, 52%. I just wrote an article about literacy in Senegal last year, and this is a big problem, is that we don't have new numbers. We should have new numbers next year on this. 52%, we would say, is literate, and a higher percentage of men are literate than are women. And of course, there's this question of like, what does literacy mean? You can be functionally literate or like fluently literate. And so there's a bit of there's a lot of bad data and questions we have around this. Maternal mortality is at 150 per 100,000 and falling. This is new to me. This is one of the updated numbers. The last I checked, it was 286. The reason I know that is because the Ministry of Health was, the last time I spoke to them about this, I thought it was about 350, because that's the number that we had been using for a few years. And the people in the Ministry of Health were last summer very, very adamant that it was 286 and that I should never publish a higher number than that. Now I'm seeing 153, which is incredible. Under 5 mortality is the same situation. Last I checked, it was 40 per 1,000. Now it's, sorry, 38 per 1,000. Now it's 40 per 1,000. Looks like it's up a tick. I don't know that that's a significant tick, but we know that over the last 2 decades, it's been going down. And so that's great. And then HIV prevalence is at 0.3%. So notably on these last 3 statistics, these are very high numbers globally, but these are extremely low numbers regionally. And so maybe something we can talk about later, I don't know, is how other countries in the region look to Senegal as a model, right, to figure out what it is that they're doing to get their numbers so low. And that's an incredible project. So without further ado, I'm going to get to our questions. I have 4 or 5 questions. We don't have to go through all of them. We're just having a little conversation here. And I want to start with our guest, Juma Nyang. Welcome. Thanks for coming. Our first question is, what are the major sexual and reproductive health issues in Senegal and in West Africa today?
So thank you very much for having me today. This is a very interesting conversation. I think the government has put a lot of focus on sexual and reproductive health in Senegal especially. So maybe my intervention will be more focused on Senegal before coming to other West African countries. So I would say that maybe the first barrier that I would think about is the social cultural ones. And so we know that in Senegal, women are often marginalized when it comes to making decisions about their own reproductive health. And so in many communities, the general perception is that women must submit to their husbands, and even on health issues. So women have to wait for their husband's approval before making any decisions. And also some choose to, for example, for services such as family planning, some choose to use family planning in secret. And when the husband discovers that, it can lead to problem within the couple. And there's also the influence of in-laws and husbands in general when it comes to decision-making. Because mother-in-laws, they can seriously compromise the use of SRH services, especially family planning services. And so if then they don't trust the services, they can instigate remorse and also apply pressure on their sons to prevent their daughter-in-laws from using them. And also when husbands are not involved in conversations or decisions about reproductive health or family planning, they feel that their authority within the household is undermined, and they're not always informed about reproductive health issues, and sometimes they believe remorse about family planning and reproductive health, for example. Another huge factor that influences SRH decisions and use of services is religion. So as you know, Senegal is a country where religion has a huge influence. And whether it is in the Christian or Muslim religion, you have some religious leaders that have a very strong opinion on reproductive health issues, and more specifically, family planning, and also the prevention of sexually transmitted diseases. And they have followers that obey them, that obey their instructions without questioning them. For example, some will tell you that using an IUD is a form of abortion, and so they will not encourage the use of long-term methods, but only natural ones. And so others will tell you that, for example, family planning is against religion because it reduces population, or that unmarried women shouldn't use family planning because it encourages promiscuity and that only abstinence is accepted. You also have some cultural beliefs around the number of children you have, which represent your social status. And so in some communities or ethnic groups, the more children a woman has, the higher her social status is. And this proves that she is fertile and worthy of being married. You also have the lack of information or remorse around family planning. So you have the lack of education and information, which have a major impact on access to services. And women that are not educated usually they have several sources of information, and they cannot always identify which ones are the right ones. and they're more inclined to believe in remorse. They tend to find it also more difficult to communicate with the health providers in general, but also they don't really know their rights in general, and especially when it comes to accessing services and also meeting their needs. And there's also that fear of side effects, which we have, I think, in all countries. And for example, some believe that by taking contraceptives, that always leads to weight gains, for example. Something that some people think that when you use family planning, you'll never have children again, or that it will damage your health. So this lack of information leads to women sometimes attributing their health problems to family planning, for example, when in fact it is due to other factors. There is also one major problem we encounter in Senegal is the lack of understanding of users' preferences. So we have no recent studies on users' preferences. We don't know what women want. And one of the indicators we had before was the unmet needs, but now we're more talking about the intent to use. What are the preferences when it comes, for example, to contraceptives? And we must acknowledge that there was a remarkable increase of the use of contraceptives methods in general, and also the MCPR, which rose from 10.3% to 26.5% in 2023. But there was a timid increase of less than 1% between 2018 and 2023. And that is due to the fact that we don't know what women want. And we're still elaborating policies based on what we are used to, instead of just trying to dig a little bit deeper into women's needs. We are,
really quick, Juma.
Yeah.
I apologize. Can you, you said about the NCPR, is that what you said?
Yes, the modern contraceptive prevalence rate.
Got it. Okay. Just wanted you to define that. Thank you. Go on.
Okay, and also one thing that I would like to flag out is that we are a country that depends a lot on donors for sexual and reproductive health products, but specifically family planning ones. So the government is making considerable efforts to increase its spending on SRH. And for example, when we take family planning, according to the recent health accounts in 2020, 1.2 billion were allocated to family planning, representing 20.8% of the shares of current family planning expenditure. And the purchase of contraceptive products represented 28.5% of those expenditures. But despite those efforts, the funding remains heavily dependent on two donors, which are UNFPA and USAID. And to give you an example of the contribution of donors to contraceptive procurement, for 2023 to 2025, we had a contribution of 83% to 88%. So there is a heavy reliance on donor funding, which makes Senegal very vulnerable to certain funding rejections or shifts. We also have the high dependence on imports because we don't have any, especially for family planning, we don't have any local manufacturers. And so most of our products are imported. And so the country remains vulnerable to shocks in the global supply chain. And all contraceptives commodities, for example, are imported, which confirms the country's dependence on imports, but also the fact that we are very vulnerable to political, health, and security crises, which can cause international transport instability. For instance, we saw that during COVID-19, when one of the main challenges for procurers was the cost of freight transport, as well as the extended delays for product delivery. And so these are also challenges that are related to, there are also challenges that are related to the market in general, such as import authorizations. And I think I have 2 points left. The other one was the women's lack of financial autonomy. So I think Dr. Powis presented the GDP per capita, and we are a very poor country in general. And so in many communities, women have limited access to financial resources. And so they do tend to prioritize day-to-day economic survival instead of using, for example, sexual and reproductive health services or family planning. And for example, with the recent demographic health surveys, you only have less than 70% of women that completed their prenatal consultation visits. And because they have to pay for transport, they have to pay for other fees that are connected to those services, but also women usually when they go to the service delivery points, they feel that because they don't have much money, sometimes they can be stigmatized and that they have less access to the right information, but also they're not really well treated when they go to service delivery points. And this brings me to my last point, which is the strained relations between the community and the healthcare providers. We have a very, I would say, tense context in Senegal, where the communities, but women in general, feel that they're not well received or welcomed when they go to the service delivery points. And so also there's that sometimes an inappropriate behavior of the healthcare providers who maybe sometimes stigmatize women or tend to say things that they should not be saying. There's a lack of empathy, but also patience towards women in general, but the community also, and the lack of communication between providers and patients. And so you can see a woman that lives in a certain community, but because she was not well treated or had a very negative experience in a certain health post or health center, she will prefer to go to a locality which is way further from where she lives, just because she does not want to experience that again. So the relationship between women and the health system is very tense, and it is compromised because of a lot of I would say miscommunication, but also misunderstanding and lack of qualified health providers. Thank you.
Thank you. Ellen, your thoughts?
Hello to everybody. My greetings. Juma, it's wonderful to meet you, even in this context. And you did all of the hard work. So I can just add a few additional thoughts. But first, let me just thank Dr. Powis for hosting, and Jesse and Patrick, who did a lot of the behind-the-scenes logistics to make this happen. So I'll start where Juma left off. I do think in the global health literature, particularly on sexual and reproductive health services, we do hear a lot about quality of care, about points of access, about the quality of the interactions between providers and women. And I think it's extremely important that Juma raised that as a strong disincentive for many women to seek out care. But if we zoom out even further to kind of look at the entire health system, I think one of the challenges is that those healthcare providers are also often not working in optimal conditions. They are frustrated. They don't have the resources that they want to do their job well. So there's a larger kind of under-resourced health system issue, and then the effects of that cascade down. So while we can invest in very targeted ways and access to contraceptives, I think there's many countries, and Senegal included, need just much broader investment in the health system in general to create better working conditions, which will also improve the quality of care that providers are able to offer, and then increase the satisfaction of people who are seeking services. So absolutely, the provider-patient dynamic is extremely important, but it sits within a much larger context that's challenging for everyone. I think a few other things that I might just point out. I think Juma did a really nice job of presenting challenges in providing services and accessing services for women whose sexuality is actually sanctioned, right? Married, heterosexual women who are seeking maternal care or contraceptive care. if we want to think a little bit about health disparities and health equity, who's not getting care or who has much more difficult time accessing care? Absolutely, sex and certainly reproduction outside of a marital context is very culturally and religiously stigmatized and taboo. So when we think about adolescents getting access to information or contraceptives or care, they're a key population that is challenging to provide services to. I think there's some really important rural-urban disparities. So, Dick presented Dakar as this, cosmopolitan, bustling metropolis. A huge amount of the healthcare budget in Senegal gets spent in Dakar and in other urban areas. And as you move farther from urban centers, the more difficulty you're going to have accessing care, and also the quality of care and the amount of resources you might find in a service provider clinic are going to change. I think legally there's some challenges in Senegal. I'll just mention two legal challenges: the criminalization of both homosexuality and abortion. So these create different kinds of challenges for seeking healthcare. If you are queer, if you are a man who has sex with men and women, if you are a sex worker, these are the populations that are difficult to provide services to. When we look at that HIV number for Senegal, Senegal has done a tremendous job, and it's done a much better job than many of its neighbors around HIV. But when we look at the HIV prevalence rates among kind of queer men and sex workers, that 0.3% rapidly goes up to about 18 to 22%, depending on the study and the time period. So thinking about who is left out, who falls through the cracks of the kind of mainstream efforts to reduce maternal mortality and increase access to family planning is a really key issue. Senegal has the legal context that it has. So, not for external donors or external actors to come in and to try to change that, but there are also, community-based organizations and other smaller organizations that are trying to work around the edges to reach, in the HIV literature, the key populations that might not be reached by more mainstream, government health facilities or the big donors, and the ways that they are approaching sexual and reproductive health. I think Juma really hit everything else, but just to point out the kind of, abortion, queer healthcare, HIV, there's some complicated challenges in that realm that often get overlooked, and that are challenging for both donors, government, and community-based organizations to work on, but are nonetheless really important if we value health equity and trying to eliminate health disparities.
Great. Thank you so much. Let's see. We have about 15, 20 minutes left, and I'm going to just sort of pop up maybe the rest of the questions. Yeah, because I think they're all pretty related. Is there? Yeah, let's do these three, and then I'll pop up that last question last. So for the next sort of, now that we sort of have the landscape mapped out, or laid out at least, I would like to know how different sectors approach these issues. So how does the government or nonprofit or for-profit organizations deal with these issues? And you both touched on it a little bit, and so you might build on that, but I think the better question, or what I'm really looking for, is the second question here, or the third question here, which is, what are the challenges that they face? And then in addition to that, what sort of strategies do you employ to overcome those challenges, but also to make sure that you're collaborating with community members and local organizations? So these are all sort of the same thought in different ways. Juma, you want to take that?
Yep, I can go ahead. So I think maybe when it comes first to how the government or nonprofits address these issues, I think that the government has realized that sexual and reproductive health it's very important actually to promote the access to sexual and reproductive health and rights, but also to ensure that women's rights are respected when it comes to sexual and reproductive health. So what they did recently was to elaborate two national policies two strong national policies for SRH, and the first one is the SRH. Is I would say in a broader way, including nutrition also, and also neonatal and child care. And then you have also the budgeted National Action Plan for Family Planning. And in those national policies, you have some interventions that are trying to target those issues, but also find a concrete way to resolve them. And I think Dr. Foley touched on that, is the necessity to invest in health. And I think the government also has understood that in a way, because in one of the strategies within those policies is to increase the availability of quality human resources in sufficient number through the revision of training curricula, for example, or also just training health providers in emergency obstetrical neonatal care, but also HIV, syphilis, and gender-based violence, for example, but also investing in the quality of infrastructure and equipment to make sure that health providers have everything that they need for their daily work. But also Dr. Foley said something very important about adolescent health, because we can see that a lot of communication was made for adolescents SRH, but we need to strengthen the communication to encourage social and behavioral change regarding adolescents and youth health. And that's also one of the interventions, but also strengthening the provision of integrated services that are tailored to the needs of adolescent and young people in accordance with standards, but also taking account the gender dimension, but also disability in general. And I would say how do nonprofit organizations support SRH? I think that although we have those strong national policies, there are still some category of people, of women in general, but also other people that are not really touched by the I would say classic interventions. And that's where nonprofit organization bring their support. So they kind of build the capacities of the health system actors in integrating some new concepts, but also training them in addressing some, I would say, sensitive topics, but also through resource mobilization, advocacy support, but also improving health statistic data. So if we see that there are some people that are not touched by interventions, that's where the nonprofit organizations can provide support and, say, okay, so we can see that policies are working for married women, but for unmarried women, it's something that is very complicated. So we come with evidence and we try to explain to the government the importance of maybe taking into consideration this category of the population. And you also have the civil society, which kind of plays a role of, I would say, watchdog to monitor the government's commitment, but also a key role in alerting and monitoring, but also advocating for a favorable environment. And all those issues around abortion in general were normally treated in we have one law for reproductive health, which is the law number 2005 of August 5. So we have that law, which actually helps us to have a very favorable enabling environment for reproductive health. But to this day, we don't have the application decree, because you have some sensitive topics such as the right of abortions that were mentioned in that law. And so given the the religious context, but also the social cultural context, it is complicated for somebody to just make the decision to adopt that application decree. So I will stop here and give the floor to Dr. Foley, maybe before talking about the challenges.
Thanks, Juma. I think Juma's right to point out that much of the policy context is very enabling. There's still some work to do. I think the government is often caught between passing progressive policies, creating a progressive policy context, but then needing to close the gap between those policies and investment and access to services. So I think that's a real challenge. I do think the NGO sector comes in the best case scenario. It tries to support government priorities and government initiatives, and it also works, I think, somewhat on the edges of filling in, I think, as Juma was right to say, some of the more sensitive topics that the public health sector can't do as directly or as publicly. I think, the organization that I know the best is an anti-poverty organization called ENDA, and they have their health wing called ENDA Santé. They're my main collaborator in Senegal, and really since the advent of the HIV pandemic, they have really been on the front lines of trying to work with communities, be a partner to other civil society organizations and to the government, and offer community-based care that's very much in dialogue with different key populations and how they articulate their own needs. And so I think the problem is, how could you scale that up to a national level, right? I think while on the one hand, civil society and NGOs can take very progressive, creative, innovative stances, they can't necessarily transform a health system in a way that provides greater equity for everyone, in Senegal. So I think one of the challenges, to go sort of right to that, is there are lots of examples of really creative, innovative, important, community-based, participatory, health justice or health equity focused work happening. But at what scale is that possible right now? So I think scale is a huge challenge in all of that. There are huge NGOs like Marie Stopes, much smaller NGOs, all of which are playing different kind of parts in a largely coordinated effort to improve access to sexual and reproductive health. Maybe since I'm sort of already talking about this, I'll start and then pass it back to Juma for some of the challenges. I mean, I think my role is very different. I'm a US-based academic. I'm an anthropologist who specializes in qualitative research and global health. And so often the way that my work really looks right now is that when partner organizations, have a need for external support around research design and or analysis, I can come in and offer the skills that I have to help them think through what kinds of data they want to collect. So just as a really brief example, the last research that I did was with ENDA Santé. They have an interesting program looking at all of the psychosocial health needs of women drug users, largely in Dakar and along the Petite Côte down to Mbour. And they have been doing some programs, some pilot programs with women drug users, but they didn't really have a good sense of the baseline health needs of these women around, their substance use, around their psychological issues, housing, nutrition, employment, economic precarity, etc. So I partnered with them to help them design a baseline needs assessment study, to analyze some of the data, and then to produce a report for their donor, which was OSIWA, the Open Society of West Africa in this case, to continue funding for that program. So a lot of my work is really working with local partners who set an agenda or identify a need, and then seeing the ways that I can help them further their own research or policy or intervention agenda. And I think one best practice that I'll just mention in terms of collaborating is that ENDA Santé is very committed to participatory approaches. They almost always bring in community leaders to help design their interventions and their assessments. So for example, in this most recent study, we had women leaders from some local organizations of women substance users who came in, who helped us design the study, and who were actually our point people helping recruit women to participate in the research and to also help us think about the data. So again, that's an amazing best practice. And I could go on and on and on about how wonderful Endosante is, but it's very difficult to scale up those kinds of approaches to have national impact. This is largely, very small or regional impact. So I'll pass it back to Juma, who can go into challenges or other approaches that she thinks are useful or interesting.
Thank you. So for the challenges, I think that the number one is that we work in a very complex setting. So when you're trying to implement an SRH project, for example, you collaborate with different people. If I take my example, I'm currently implementing a social accountability project for family planning. And so you need to get the government's buy-in, for example, because the way those projects are structured is that you have to work with the health representatives at each level, at the national level, at the regional level, but also at the community level. So unless you can have the best project ever, but if you're not able to get the government's buy-in and make them understand that this can benefit the community, although it's going to change their way of working, you might not get the results. And so you have to take into consideration also that you will work with government members, you work with other organizations, with community members in general. And if I take also the example of social accountability, you are trying to you're trying to increase, for example, the woman's voice in a community. But for that, you have to work with religious leaders, you have to work with the health personnel, you have to work with women, with husbands. And it's just, how do we collaborate? Like, what are the collaboration approaches that we can have to make sure that all those people that are essential to the success of our project can actually see an interest in this project, but also how do we make sure that we take into consideration their different ways of thinking, but also their cultural beliefs, which are deeply rooted, but also religious beliefs, and just try to navigate. And so there are also sometimes the unforeseen events that influence the implementation of activities. If I take the context of Senegal, we had the recent elections in March 2024. And because of the uncertain political context, this influenced the implementation of our activities. And we had a delay in a lot of our intervention just because of that. And on the other hand, you need to actually, you have goals, you have a work plan, you have a timeline, and you have to make sure that given all these issues, that maybe these obstacles that you're facing, you can actually find solutions. And this may be, I will continue with the next question about the strategies that we can employ. So for family planning, but also SRH, and because I've also worked in other projects for women empowerment. Before this project, I was working with the on supply security, the market in general for SRH products, before going on the social accountability project. And the number one thing I would say is working in partnership and setting clear communication channels, but also project coordination mechanisms. So when you have a new project, you want to make sure that you identify all the people that will play a key role in your project. So it's going to be the government, it's going to be other organizations that work in the same field. For example, for me, when I talked about market but supply security, we had to involve USAID, Chemonix, UNFPA in discussions, FHE 360, MSI, ENDA, but also ADEMAS, for example. So all these organizations in the conversations to make sure that there's not a duplication of interventions, but also we can see how do we complement our interventions, and we're on the right track. And also in this case, for the social accountability project, it's the same thing, setting up a task force at the national level, but also at the project implementation sites, to just make sure that everybody understands what you're doing and that the results that you are getting can be appropriated by the community in general, but also by the government. And so maybe the other one, I would say co-designing activities and interventions. And that's one of the approach we decided to implement in this project, having co-designing teams, because usually the problem with development projects, or like I would just say development in general, is that you have projects that are elaborated at the higher level, and that they come to our countries, but they're not really tailored to our context. And so it's very important to make sure that we stop having that top-down approach, but rather have that bottom-up approach where you discuss with the beneficiaries, the people that are to who this project is that are the targets of this project, and to just make sure that you collect their feedback. You just create activities with them, interventions, involve them in decision making, and that this is a very transparent process and a very inclusive process in general. So I would say those are the two most effective strategies I can think about.
Great, thank you. And I would like to move on to this last question and maybe save a moment for at least one audience question. This last question is, aside from my global maternal child health course, which is being offered in the spring, what courses should students take, or what skills do students need if they want to do the work that you do, if they want to follow your career path? Either of you can start that.
I'll jump in really quickly. I'll be very quick. I think humility is probably one of the most important skills. And I think, just, as Juma was saying, if you're part of an organization, wherever you work, if you want to have genuine community engagement and inclusion, you really need to be able to be comfortable in many different kinds of spaces. And also to be able to recognize that in any given setting, you might be the person with the least amount of expertise, and you need to listen to everyone else in the room to come to a good project or consensus about the way forward. I think for US students, language skills, but please get cultural fluency and linguistic fluency in another language besides English. I think qualitative research skills are very important. I would also really encourage students to take an epidemiology course, right? I mean, to really feel comfortable understanding quantitative data analysis, what epidemiological analysis can and can't tell us. And I think then just, compassion and curiosity, a desire to learn and understand, and to always assume that you don't know everything about a given issue or topic that you're working on are the kinds of things that I would encourage, a mindset that I would encourage, anyone working in public health or global health to embrace. And I'll pass it back to Juma.
Thank you.
I would maybe say first, the collaboration in general. You need to know how to collaborate with people, because you're not going to succeed in this work without knowing how to collaborate. I would say also you need writing and reporting skills, because in this type of project, and I think you're all very used to it, given your context, really have strong writing and reporting skills, but also analytic skills. As Dr. Fodi said, you will have to conduct many researches, let it be the formative research or other type of research. So you will collect a lot of data, and then you will need to analyze that data to draw a conclusion out of that. And those are skills that you need to have. I would say also adaptability and flexibility, because nothing, sometimes you can have a very good work plan, everything is set, the deadline, everything, you know where you're going, but you will always have some unforeseen events, and you really need to know how, when facing some difficulties or obstacles, how can I find alternatives and just adapt in general. You also need to be, I would say, have very good skills when it comes to conflict resolution or problem solving. Because sometimes you might be in a workshop talking about maybe, all women need to access, or for example, adolescents, young adolescent women, they actually cannot access SRH services. And maybe somebody will say, oh, they don't need that because, they're not married. And so that can spark debate in the room. And then you need to know how to maybe reorient the discussion, but also find a smart way to tell people, maybe we should have a different way of thinking, or just trying to find alternatives. So yeah, thank you.
Thank you both. I think we have a moment for one question here. And I'm going to go with Raja Mbenge's question. It looks like two questions here, but the question is, how do we improve referral services and implement strong feedback and complaint mechanisms to increase the incentive to use SRH services? So this is sort of a health systems question for sure. Yeah. And well, I'll let you both answer. I have thoughts, but
I'll let Juma take that one.
Yes, okay.
I think it's tricky, right? And I guess the one thing that I would say is it's complicated to think about feedback and complaint mechanisms when basic service provision is still challenging, right? So what do you tackle first? What's the order of priorities of improving the functioning of the health system? But Juma, if you have more specific ideas about this particular question, I'd love to hear them.
This is exactly one of the part of the work I'm doing. And so
so that means you planted this question in the audience.
No, so I actually work in social accountability, and when we talk about social accountability, it's just trying to make sure that the citizen, the community in general, have a say in the services that they receive. And well, we know that there are a lot of issues in the health system, but one thing that is very useful to have this feedback mechanism and all are community dialogues, for example, in Senegal. So we do have community dialogues, but we don't have that part of community dialogue which allows us to do the monitoring, but also have a strong resolution framework or plan in general. So one thing that women suggested in general, but also health workers, is to have indicators at the end of, for example, each social accountability session of community dialogue, and just have indicators that would track the performance of the health system in response to the issues that were voiced by the community. And so at the health structure level, you maybe have what you call I would say scoring mechanisms, where maybe you have that red button, yellow and green button when the woman goes out of the midwives, for example, office, she just can click on one button, or there's another feedback mechanisms that allows her to say what she wants, because let's not forget that we are in a context where people are not really do not really have a high instruction level. So maybe we're still thinking about these solutions, have a system that could allow women to express what they experience in that, but also on another hand, having an office at the health facility level where women can actually go and say, you know, this is what I just experienced, and making sure that the head nurses at those health facility level get those feedbacks, but also that they can be shared with the higher authority, which is the medical head, the head of the medical district, to make sure that, you know, there's that accountability for those services.
Yeah. Yeah, great. I'm having all sorts of thoughts about, you know, I have some sort of a little bit of experience with the health worker unions and the nurses unions in Senegal, and I just, it sounds great and I want to know more, but I'm also thinking about those unions, right? And how those unions respond to those things, and if they're going to be more or less sort of accepting of those sorts of systems, right? Because obviously you're going to want their cooperation on those things too. I feel like I did just see one of those green, yellow, red lights in Hôpital Principal when I was there over the summer. I don't remember. And I remember thinking, what is that? Yeah, I sort of figured it out, but very interesting, very interesting. That brings us to the end. Thank you so much for coming. Thank you to the participants. Thank you to the audience. As we mentioned before, everything is recorded and will be on YouTube soon. Anything else from Jesse? I don't think so. Okay, great. Have a great day.
Thanks, everybody. Juma, we'll look you up next time we're in Senegal.
Yes, it will be a pleasure for me.
For sure.
Okay. Take care,
Thank you.
everybody. Thank
Okay.
you. Bye-bye.